Our next presenter is Elizabeth Evans. It's a fourth-year medical student. She's going to present on behalf of the group from Medical University of South Carolina, and the title of her presentation is Laser in-situ fenestration for revascularization in thoracic endovascular aortic arch repair, a single center analysis. Go ahead.
Good afternoon, everyone. My name's Elizabeth Evans. I'm a fourth-year medical student at the Medical University of South Carolina. Thank you for the opportunity today to present our experience with in-situ laser fenestration for aortic arch repair. These are our disclosures. I've been looking forward to telling you all about lasers for a while now, so I hope you're as excited as I am. TEVAR has become the preferred method for repairing most descending thoracic aortic pathology. Compared with open repair, TEVAR has several known procedural advantages, such as avoiding thoracotomy or sternotomy, and elimination of the need for aortic cross-clamping or cardiopulmonary bypass. The main caveats with TEVAR is that there's shown to be no difference in mortality in the long term. There's a higher rate of reinterventions, and the method is limited by an inability to manage the arch vessels. Given the advantages, for some time there's been interest in advancing the application of TEVAR across the arch. Prefabricated devices have existed in trial form, although they're not yet readily available in this country. In order to overcome this, several methods of managing the arch vessels have been described, such as parallel endografting, physician-modified endografts, and in-situ fenestration. Today, we'll share our experience with the in-situ fenestration technique. Over the last 3 years at our center, we've treated 24 patients with TEVAR with laser fenestration. Each of these patients was evaluated by an aortic team that consisted of cardiothoracic and vascular surgeons and was deemed unfit for open surgical repair. Also, during the informed consent process, each of these patients was informed of the investigational nature of the procedure. Landing zone was selected to ensure at least 2 centimeters of seal, with devices oversized 0 to 10% for acute dissection and 10 to 20% for all other pathology. X-ray anatomic debranching was performed selectively at surgeon discretion. Laser fenestrations were created using a 2.3 millimeter 7 French 035 Spectranetics laser, which was advanced in retrograde fashion from the target vessel. Each fenestration was pre-dilated with a 4 millimeter balloon, followed by placement of a covered balloon expandable stent with 0 to 10% oversizing to the target vessel. Each of these patients was maintained on dual antiplatelet therapy, except in those cases where a spinal drain was utilized. Cerebral oximetry was monitored intraoperatively in all cases. The majority of these 24 patients were male in their 60s and 70s, although we did have several younger patients, one as young as 24. The majority had typical risk factors associated with aortic disease, such as hypertension and history of smoking. Half of these patients had prior aortic repairs, a third having prior open thoracic aortic repairs. We had a near even mix of emergent versus elective presentations. The indications spanned a variety of aortic pathologies, a third being degenerative aneurysms, 1/3 chronic dissections with aneurysmal degeneration, and another third with acute dissection spectrum pathology. The technical success rate at our center has been 100%. Half of these cases involve zone 2 proximal landing, with left subclavian artery coverage alone, and the remainder covered further across the arch. About 2/3 of these cases involved one fenestration in the aortic stent graft, and the other third involved 2 fenestrations. One of these was at the takeoff of an aberrant right subclavian artery. The majority of the fenestrations were created through percutaneous radial access, with percutaneous brachial and alternative open access for the remainder. The open access cases were utilized predominantly when concurrent extra-anatomic bypass was being performed. Half of these patients had an extra-anatomic bypass, most of which were performed concurrently with the TEVAR with laser fenestration. 6 of them had 1 vessel bypassed, 5 had 2 vessels bypassed, and there was 1 patient with 3 vessels bypassed. Earlier in the series, 6mm PTFE was used for these bypasses, and later on, 8mm Dacron was preferred. In the perioperative period, 58% of patients experienced a complication, most of which were minor. There were 2 strokes, one that occurred at 12 days and one at 20 days post-op. 2 deaths occurred within 30 days of the procedure, and both of these cases were for emergent indications. One was on post-op day 1, presumed secondary to extensive bowel ischemia, and the other occurred shortly after discharge, and the exact reason was unknown as an autopsy was not pursued. Over a mean follow-up of 261 days, ranging from 2 weeks to 2.5 years, there were 3 additional late deaths due to non-aortic causes. 7 of these patients have required reintervention at a mean time from index procedure of 46 days, ranging from same day to 140 days. And these reinterventions included 6 cases of embolization or stent extension for endoleaks, 1 intervention with balloon angioplasty for bypass stenosis, a delayed bypass for treatment of endoleak, and a washout for neck hematoma. So a few take-home points from our center's experience with laser in-situ fenestration and TEVAR. For one, we're finding it safe and effective for treating various pathologies of the thoracic aorta in patients who are unfit for open surgical repair. It's showing to be feasible in both elective and emergent settings. Its morbidity and mortality profile are favorable to that associated with open repair of thoracic aortic disease. And like TEVAR in general, it does have the caveat of a high reintervention rate.
Really nice job with your presentation and and also, great outcomes from your group. I have, while we wait for questions, I have a couple. The first one, is there a preferred endograft that the group uses for laser fenestrations?
So at least in our experience, they've used Cook, Medtronic, and Gore, but I'm not sure if at this point, if there's a preferred one. Dr. Wooster, if you could add to that.
Gore is a little more challenging because it has a lot of metal. Outside of that, it's really dealer's choice. This additional spacing between the struts on either the Cook Alpha or the Medtronic or the Bolton Relay even really make them all pretty similar capabilities.
We have a couple of questions. One from Ravi Rajani. Were either of the strokes felt to be due to a branch vessel complication?
Yeah, so the strokes were on post-op day 12 and another one on post-op day 20. And going back through that documentation, when the stroke service evaluated them, they kind of listed several possible etiologies. In both cases, they were like bilateral, multiple, and like deep white matter types of strokes and weren't thought to be from major vessels in etiology. But they did include the post-procedure embolization as a possibility in both of those.
Another question, can you tell us about the late endoleaks and the interventions in your series? It looks like it is around 16%, which is unusual after TVAR. Was there fabric tears around the stented fenestrations?
So all these patients who had reinterventions for endo leaks were dissection patients. Dr. Wooster, if you could comment on that as well.
Sure. We didn't have any endo leaks in the aneurysm patients. They were all dissections, and they were all secondary leaks from the false lumen. And so they were issues with having to further extend the branch stents or coil embolize the false lumen in the subclavian or the innominate. There were no branch vessel occlusions. There were no migration. There were no fabric tears. It was all due to predominantly subclavian artery issues where the dissection extended very close to the vertebral artery. So we tried to save the vertebral artery by landing short with our stent, knowing it would leave false lumen behind. And as expected, we had to come back and treat the false lumen.
A question from Nate Ross. How was it decided who underwent fenestration versus extra anatomic bypass and debranching?
Yeah, Dr. Wooster, I think you'll have to answer that one.
Yeah, I'll take that. It's really preference, quite frankly. Fenestration technique is certainly faster and easier. It avoids additional prosthetics sitting in a relatively shallow subcutaneous tract. And then it has to do with distance between the branch vessels and the arch. If they're too close together, you can't really comfortably create fenestrations for each one. And so that's why you'll notice that there are very few patients where we do 3 fenestrations. Most of them have 1 or 2 with extra anatomic debranching thereof. And we found that 2 is predominantly our preference. 3 tends to be a bit too much. It tends to infrequently have enough spacing on the arch. And 1, we've had issues with cerebral hypoperfusion. And so rather than living an entire brain and upper extremity off of a single fenestration, we've been much happier doing bilateral carotid subclavians and creating at least 2 fenestrations.
So along those lines, the next question, when performing 2 fenestrations, is there a certain distance or criteria that you use? And any concerns of fabric tears if you are real close?
Yeah, there's no hard number for that yet. It's sort of gestalt. I would say they need to be at least a centimeter apart, but I have 0 data to support that. That's 100% gestalt. I think closer than that, you have the challenge of coming off at a slight angle, and you do give yourself the risk of creating fabric tears with them being too close. The same as any of our company modified fenestrated devices have limitations to how close they're willing to build their fenestrations. I think you run the risk of creating integrity issues within the graft, but that's purely a gut sense.
Matt, can I ask you a question? I think these are really complicated, and I'd like you to talk a little bit about the technical aspects of creating the fenestrations and getting the lasers to come down on the graft, because I think a lot of people just think, oh, you put the laser in and you make the hole, and that's not how it works. There's you have to be very technically inept, and you have to pay attention to how the laser is lining up. So can you chat a little bit about that?
Yeah, so you definitely have to be cognizant preoperatively of the tortuosity of the branch vessel you're choosing. Left subclavian in particular tends to be very angulated, and the innominate tends to be very angulated. And so you want to choose the straightest path possible. Most commonly for innominates, we come straight down from the carotid rather than coming from the right radial. For the left carotid, if we do a carotid subclavian, we oftentimes take the left carotid for our access point rather than coming from the subclavian. We've even gone left radial through a carotid subclavian and then come down the carotid because it's a straight shot that way. You have to take multiple obliques with your II. You want to do a live roll with your C-arm to make sure you're looking at it in multiple projections, and you need to really be sure that you can tell you're pushing on the graft fabric. A second thing that we've done to help is we will oftentimes keep IVUS inside of the graft right at the level we're going to fenestrate, and you can appreciate the graft fabric being indented on the intravascular ultrasound. Gives you a high level of confidence.
I really appreciate you mentioning that, because this is not something I think you watch a talk on and you just decide you're going to do. You have to really be mindful of a lot of things for this. So thank you.